in the U.S., and if it was having a very robust treatment effect, we probably would have seen it. So if it's positive and it's having an effect, it's not an effect that's very apparent.
Not very apparent. Joining me now is Dr. Stephen Smith, founder of the Smith Center for Infectious Diseases and Urban Health. Also with me is Dr. William Grace, former chief of medical oncology and cancer research at St. Vincent's Hospital in New York. All right, Dr. Smith, of course, that was former FDA Commissioner Scott Gottlieb. And like Dr. Fauci, never seems to be all that wild about hydroxychloroquine. And your experience that you've been documenting night after night with this drug and your COVID patients is what?
It's very impressive. As I discussed last night a little bit, that we're seeing responses like you'd see with someone with a severe bacterial disease. In other words, when someone comes in with a severe bacterialness, antibiotics aren't going to matter. You know, it doesn't matter how many antibiotics we give them. They're too sick to help. And that's what we're seeing here. Except it's not just the timing. I think it has to do with the dose. And actually, I think we need to give more hydroxychloroquine earlier to help the obese patients. We're seeing plenty of patients that are well over 100 kilograms or well over 220 pounds. So we have to give that drug more and earlier rather than later. We have to treat it like the malaria dose, which is over a gram and a half right up front. So I think that it's key. The differences are dramatic. We know the combination of hydroxychloroquine and azithro work. That's proven. I guess he didn't hear my data and hear about the Chinese data as well as the French trial data. It's unequivocal now.
Yeah, it's unequivocal now. It's a cheap drug. It's actually easy to make. And Dr. Grace, you were on the show 2 weeks ago, over 2 weeks ago, when we were talking about this. And now there was a global health survey of doctors, and that just came out today. And it's the go-to treatment for doctors who are treating COVID patients. But Dr. Grace, you weren't surprised about this at all. You thought that that's the way it was going to go down from the beginning.
That's right. In fact, all my colleagues who are treating COVID-19 patients find that the drug is working, and it's working better when you give it earlier in the course of the disease. We give it to everybody in our hospital who is basically hospitalized with COVID-19 symptoms. And they're finding that fewer people are getting to respirators and people are getting discharged faster because of that. They also use azithromycin with it as the standard protocol for admission patients with COVID-19. There are many doctors that are in the community who are treating walking wounded with hydroxychloroquine with or without azithromycin and finding the same clinical benefits.
Dr. Smith, you and I talked last night about your patients' preconditions when they come in, and that they already have underlying conditions, many of them. Obesity being one, and a high BMI, body mass index. Reuters has a big article tonight about New Orleans. Why is New Orleans' coronavirus death rate twice New York's? Obesity is a factor. Some 97% of those killed by COVID-19 in Louisiana had pre-existing condition. Diabetes was seen in 40% of the deaths. Obesity in 25, chronic kidney in 23, and cardiac problems in 21. Dr. Smith, the statistics on the number of people who come in and die who don't have an underlying condition is obviously then quite small, correct?
Right, quite small, and especially with the therapy. I think there's a couple of things about diabetes. I think they're more at risk. They also accelerate more quickly. So they have not just the risk of serious illness, but the risk of really rapidly developing that serious illness. So you have more time to get to the non-diabetic with treatment and have that treatment kick in, because it is that cumulative dose of hydroxychloroquine, which I think is the key to the therapy. And with non-diabetics, you have time to get there. With some diabetics, you don't, because there seems to be a feedback loop where the infection makes the diabetes harder to control, and the high blood sugars then makes the infection harder to control by the immune system or the therapies. So there seems to be this weird feedback loop that makes it more rapidly sick. So the therapies work better, or the hydroxychloroquine and azithromycin therapy works better in the non-diabetic group because it's a slower disease.
All right. And Dr. Grace, really quick, the USS Comfort, that big naval ship that arrived in New York, and everyone's very happy about that. It's going to treat non-COVID patients. Apparently, the New York Times reporting tonight that it's mostly sitting empty, infuriating local hospital executives. The ship's 1,000 beds are largely unused. I guess they have 3 patients. What's going on there?
I think that right now, not all the hospitals are at excess capacity. There are certainly those hospitals in the most densely populated areas and the areas where there's more diabetes and obesity. Those hospitals are overwhelmed. And I think that the other hospitals around the city where there's less obesity, less people are thinner and maybe more active and don't live in an area where, 3 generations live in 2 rooms. Those are the hospitals that basically have not the problems with overextension. And so you'll see that in Central Park, that hospital is so far not seeing patients, and the ship that's in the harbor is not getting that many too. Right now, we're not at capacity for most hospitals.
Well, let's hope that continues, and that model was not accurate, and we're not going to be able to, not going to get to those really disturbing numbers, since that was the whole point here. And if they take hydroxychloroquine, as Dr. Smith said, that is a game changer here, and keep people out of the hospital perhaps